Thank you, Astrid. I call now on stage Marius Geanta, President and co-founder of the Center for Innovation in Medicine. And Marius will tell us a great example of going from policy to practice, Romania's right to personalized medicine and the implementation of personalized prevention. Welcome, Marius.
Good morning, all, and thank you very much, Angela and Astrid. Indeed, from policy to practice and back. And my presentation was actually advertised yesterday and today by Astrid. No pressure, no pressure at all. I will start by saying that I was there in 2011 in Brussels at the first European Commission conference on personalized medicine. I just finished in 2010. I'm a medical doctor by background, but then I studied public health. And in 2011, I was trying actually to find, something interesting to do. And going to Brussels for personalized medicine, for me, was an intellectual challenge. And I've seen a lot of opportunities, and I was excited, But then going back to my home country, to Romania, I haven't seen the same level of excitement and interest on this topic. And I said, okay, but I truly believe that this is something important, personalized medicine, but how to move forward? And together with some of my friends and now colleagues, we decided actually to set up an organization called Center for Innovation in Medicine, INOMED, in order to put personalized medicine on the agenda in Romania and to start really working on this. And we are actually guided by this continuous loop. We started with science and innovation. Then we try to influence the policy and regulation, and I will present you how we actually managed to catalyze the first in the world law on the right of the citizens and patients to personalized medicine, and then moving towards implementation, trying to extract learnings, to generate science and to innovate, and then to influence again the policies. Immediately after the Council conclusions in 2015, in December, it's all about, perseverance and serendipity. Because I attended the meeting in Bucharest, and one of the people there was just announced to be the health advisor of the Romanian president. A professor from the medical university. We previously worked in other projects, and I said, Diana, this is a topic of interest for me, personalized medicine. What about doing something under the umbrella of the Romanian presidency? And she immediately said, absolutely yes. Okay. And what came next was that we organized a high-level event in 2016 under the umbrella of the Romanian president. And this was really great because, it's something to be invited by a not-for-profit like INOMED, and is something different to be invited by the Romanian president. And we managed to have academia, high-level politicians, researchers, patient advocacy groups all together in this meeting, and we did the same in 2018. And then what happened were, of course, the developments around Europe's Beating Cancer Plan and Cancer Mission, and one day I received a call, it's all about calls, from the health advisor of the president saying, Marius, the president is interested to develop and to have our first national cancer control plan to be aligned with the Europe's Beating Cancer Plan and the Cancer Mission, and I would like to involve you in this working group. And I said, okay, but what will be my task? Personalized medicine, of course. And then, started like a movement at the national level to work on this. And the NCCP was approved as a law in 22. But in this process, again, we identified, we made other relevant persons. And one of them was a former pancreatic cancer patient, but a member of the Romanian Senate. And she became really interested, how to improve the legislation when it comes to patients' rights, when it comes to cancer, and so on and so forth. And Senator Pauliuk started to ask different people, what would be of interest for you to put in the national legislation and what will help you. And this is how actually came the idea of improving the national legislation with the right to be forgotten. It's a law now, and other 2 or 3 laws. And one day, again, Senator Pauliuk called me, and I said, what about putting personalized medicine in a law as a right for the patients and for the citizens? And then, the process was quite easy because the National Cancer Control Plan was approved by law, so they all know the parliament what was the procedure. And this is how actually in 23, in the spring, the law was promulgated by the Romanian president. And we were very happy with that. But in this process, so this is, let's say, what I already mentioned was very personal, how actually things happen. But my organization, INOMED, and my team, we actually work very hard all the time, actually, to continuously engage with the relevant stakeholders. As you can see, we develop engagement projects dedicated to academia, to public sector, to private sector, and to civil society. And when we started, to do this type of engagement, I didn't know that this has a name, pentahelix, right? And this is the model of actually engaging all the stakeholders. And this is the model that now in the framework of the cancer mission is put forward by the ECOS consortia. ECOS is aiming to establish the national cancer mission hubs. And in this model of stakeholder engagement in pentahelix, very important is the role of the convener, who is able actually to catalyze and to put together all the stakeholders. And the second most important part is the distributed leadership, because the topics are different, and you should rely on the expertise of different groups for a certain topic, and the others should trust the others, and the other way around. So this was the model. In terms of different key aspects of the law, this law complement the law of the patient's rights. We've put in the national legislation the definition of the personalized medicine according to the council. Of course, some remarks about informed consent, and healthcare professionals should provide to citizen and patient all information, including risk-benefit. So basically, the law paved the way for what will be the European Health Data Space implementation in the national legislation and so on. But more important was, what was the impact of having such a law at the national level? And I think the developments were really, really interesting, because what we did immediately after the law was to engage with the Minister of Research at that time to say, maybe it's time now to sign the 1+ million genome declaration. And this was like a guerrilla type of action, because we were like 4 people working for 4 months to have a memorandum from the government, and finally the declaration was signed. And this was really great, because then in the fall of 23, Romania joined the GDA project, Beyond 1+ Million Genomes Plus project and EDIC initiative. And the national level, very interesting, is the ROGEN project, 85 million euros allocated through the EU-funded operational health program. And then the National Institute for Genomic Research and Development was established in 22, and now it's operational. And very interesting, in October this year, Romania finally joined Elixir. This is very, very important, I think. And last week was just announced this investment, around 20 million euros, again, through this operational health program, the establishment of the first CAR-T clinical research lab, part of the biggest Romanian hospital. And starting January 26 next year, we'll start working at the first national strategy for genomic medicine in Romania. I have to say that, preparing the slides for this meeting, I was, a bit surprised to see so many developments in about two years in Romania, and all strategic and all top-down. in terms of governance of all this project, is very easy because you simply look to the Olympus, right? And you can see a lot of gods. And probably the most important here is the Kairos, is the god of the opportunistic time. It's always very important, of course, to be continuously engaged in the environment where you are actually working and acting, but always to identify the opportunities, the moment when is the time actually to act, to do something really, really concrete. And all these gods somehow aligned, and I'm speaking now from INOMED perspective, because we have been quite successful in the last 3 years to coordinate some EU-funded projects and to contribute to other projects. And this is the part of my presentation when I will stop the top-down approach and I will go to bottom-up. Because we actually seen these European projects, not just European projects, but a way actually to implement personalized medicine and in particular personalized prevention in Romania, in addition to the top-down implementation, the low-end, and the other developments. And I was referring that with these projects, and I will pay attention to the project I coordinate for PCAN under the Cancer Mission, we actually use the synergies with PROPHET, and this is the definition of the personalized prevention coming from the PROPHET project. And I think this is a very comprehensive definition because really pay attention to all determinants of health, not only biologic and genetic factors, but environmental, health system related factors, and very, very important, social factors, socioeconomic factors, and individual behavior. And social factors and individual behavior contributes with 60% from the total of the health determinants. And this area is not very well covered. That's why we need, and I will show you how we actually did in our projects, the integration between health, STEM sciences, and social sciences and humanities. I already mentioned the 4PCAN project. It's a really complex one, not just because we are 19 partners from 11 countries working on the 14 now recommendations of the European Code Against Cancer. But in the project, we are actually covering the topic of the cancer primary prevention from a macro perspective. So we map the legislation, regulations, directives at European and national level in relation with the 14 recommendations of the European Code Against Cancer, but also we went at meso and micro level, trying to really understand what is happening at the individual level, what is happening in our personal networks, in our communities, and in the society. And I will show you some examples from a living lab we set up in the center of Romania. So we decided to build this bottom-up model of the European Code Against Cancer implementation in the center of Romania, in this small village, 4,000 inhabitants. And we choose to start from these rural settings because on one side, these rural settings experience a low access to healthcare, low access to health innovation. They experience the digital divide, and 50% of the population across Europe are actually living in rural settings. And if we'll be able to come with a model and to show how in this kind of rural settings, the European Code Against Cancer can be implemented in a bottom-up manner, this I think would be very useful not only for Romania, not only for Eastern Europe, but for Europe overall. And as I mentioned, what we did was to set up a living lab. So from a conceptual perspective, a living lab starts with the idea, in our case, how to improve the uptake of the European Code Against Cancer in a rural setting. And of course, this should be based on needs assessment, brainstorming session. Then you build kind of prototype, you develop a concept, and then you go towards implementation. pilot projects, of course, you collect data, and it's very important to always have in mind how would you scale up what you are doing in very small areas, and of course, the evaluation, impact assessment, and dissemination are very important. It's brilliant. From a theoretical perspective, it's brilliant. It's fascinating, right? But you don't know what to expect when you actually go in communities and you meet real people. And this is my car. In the first day of implementing the health festival last year, in 24. Yeah, so this is my car. And the crash was between my car, wasn't something serious, and another car of a citizen living in this village in Lărești. And in a few weeks were local elections, and this citizen was elected. And now he is part of the local committee working with the mayor. So I don't know if this is citizen engagement, but, but maybe we can consider like a funny way actually to build local connections. And a key message is here. It's really important not just to engage with the social scientists and to go top down, to say we are the experts, please answer the questionnaire, but to really immerse in the communities, to go there, and to be able to capture what is relevant for the people living in the community. And what we did, and I'll explain you from two perspectives, the stakeholder perspective and citizen perspectives, was to go in the community, and we are really interdisciplinary, multidisciplinary, and transdisciplinary team. So we are doctors, public health experts, data scientists, social scientists, psychologists, psychiatrists, nurses, a big team. And we went in this community, and what we did at the stakeholders level was to use social scientists to understand the full landscape of the stakeholders. And we did this nice exercise, trying to understand the stakeholders at European, national, in yellow, and regional level. And it's not just about the numbers. We identify 130 stakeholders relevant for the cancer primary prevention. Usually, the implementation, top-down implementation models involve around 10 stakeholders. But this exercise helped us to understand who are the most relevant stakeholders for the community. And this was a surprise for us, because at the local level, for the cancer primary prevention, were the local authorities, not the primary care doctors, as the most important stakeholders to work with. And we started to engage with the mayor and with the local committee. And then what we did was to go and to engage with other mayors from the region. This is from the scaling up perspective. And this was really informative for us, because if we went the traditional way of implementing the European Code Against Cancer, we'd probably go to primary care doctors or to public health authorities and do this type of engagement. Totally different than what is actually relevant in practice. And we organized in March this year this meeting with other 15 mayors from the region, and now the project is actually scaling up across this county. So it's clear that the social sciences and humanities should play an increasing role in cancer prevention. And from the citizen perspective, what we did was to use social and personal network analysis to understand what is relevant for the people, and very important, how different behaviors and attitudes spread to social in our personal networks, and who are the influencers at the community level. And as you can see, we performed this PNA, stands for Personal Network Analysis, and then we organized the citizen engagement activities, and so on. So all the time, we use the social sciences before doing anything with and for citizens. And this was very informative, because this helped us to understand the high level of stigma at community level. And we decided not to communicate the European Code Against Cancer, but to formulate in a positive way, and we call this Code for Life, because the stigma is very high and you cannot introduce cancer who is stigmatizing and can become a barrier immediately, and so on and so forth. And what became really interesting this year and last year was this synergies between 4PCAM project and other projects. And you can see on the right side, Maya project, Perfecto, Carton, and Careway. And European Commission and HADEA, they didn't ask us to build these synergies. But people living in the community, they asked us not to apply and to be successful. But they said, you know, to our colleagues, of course it's important for us to understand why we should quit smoking now. But you know, I have a real issue to have access to a cardiologist. I have a real issue to have access to a basic ECG. I should wait 3 months to do an ECG. I have some cardiovascular comorbidities and so on and so forth. So for us, the learning was, if we like to be successful in implementing something on cancer prevention, we should really look to the full picture of risk factors, of multimorbidities, access to care, and so on. And this is how we actually started to generate scientific evidences and then to really offer something concrete to the people in the community. And we have been actually really Democrats, and we didn't want to go in front of the audience and to say you should quit smoking, quit drinking alcohol, eat healthy now, starting today. No chance. But what we did was to present the recommendation of the European Code Against Cancer in this town hall, and we asked people to choose what are the topics of interest for them. And they choose obesity, nutrition, and physical activity. And of course, then we build different programs for each of them. But on physical activity was a challenge because there are a lot of people with suffering from different diseases, with comorbidities, elderly people, and so on. And what we offered to them was walking football activities. So he's playing football without running, without hitting the ball too much. And you can see on the right side was my team, a really diverse one. As you can see, all ages, and yeah, we actually participated in this tournament, and this picture is from 24. And this year we organized this health festival, and where 7 mayors from the region coming with their teams and participated here. And now there is an interest from the county council to organize this kind of event across the county. And this is a way actually to promote physical activity, but also to spread the message about prevention. Because part of this health festival was not just to promote sport, but to do different type of assessments. And what we did was to calculate the cardiovascular risk and to include lipoprotein A, is an independent inherited genetic risk factor for cardiovascular diseases in this assessment. And as you can see, 53% of the participants fall into high and very high cardiovascular risk. And this is really incredible. And we use an AI-based algorithm for this. And the visualizations coming from this algorithm were very, very useful to really implement personalized medical counseling for these patients. And if you like to find more about LP-little-a, you can see here the LP-little-a International Task Force. I'm very happy to be in the core group, and Magdalena is here because this initiative is driven by FH Europe Foundation. What is, I think, highly relevant for what we are doing, 2 minutes, is the way we do the research. We are not doing the type of extractive research, but we are really promoting a participatory research. We are not going in the community to extract some data, but we are actually working together. And the way to do this, so our colleagues from social sciences, they collect data for waves. Then they analyzed data, and they did very nice visualization of the data, of the networks. And what we did in this September was to organize an exhibition and to invite people who contributed with data to show the visualization of their own data. So I think this is a nice way actually to close the loop and to re-engage with the community and with the citizens. And one of my favorite experiences was last week. We did this AI consultation with real people from the citizen jury from this community. And it's so interesting actually to speak about AI with real people, and more details will come in the future months. We are really building a model of continuous engagement with the citizen, as Christine Chaumian, the vice chair of the Cancer Mission Board, mentioned, the kickoff of our project. And what we are doing is part of the personalized prevention. This is very clear. We have strong links with Prophet, not only because Stefania Boccia is part of our consortia, but really what we're doing is to really define these social and community, social factors and community-based factors, and we build a social infrastructure where we can go now to test different interventions from AI, smart meters, polygenic risk scores, genomics, and so on. And with that, thank you very much.